Hello, and a very warm welcome to this webinar entitled Why Genetics Matter in Cardiomyopathy. My name is Nicola Bedlington, and I have the honour and pleasure of moderating this 1-hour session today. It's organised by the Global Heart Hub, a global patient organisation striving for cardiovascular health and supporting patients in cardiovascular disease. Also, together with its Cardiomyopathy Patients Council, which brings together patient leaders and their organisations focused on awareness raising, improved diagnosis and management for patients living with cardiomyopathy, their carers, also collaborating closely with healthcare providers to really ensure the best possible outcomes for this community. The webinar will explore why genetic testing is important in the area of cardiomyopathy and the role of genetic counselling. And we'll kick off with insights from a renowned expert in the field, and we'll then have the opportunity for a Q&A, bringing in also a specialist in genetic counselling for cardiomyopathy. Please do post your questions on an ongoing basis throughout the presentation, and we'll try and address as many of those as possible. So without further ado, allow me to introduce you to Professor James Ware, who is Professor of Cardiovascular and Genomic Medicines at Imperial College London, amongst many other accomplishments. James, we're delighted that you're with us today, that you're able to join us today. A very, very warm welcome to you. And it would be great if you could kick us off with a bit of background around genetics and cardiomyopathy, please. The floor is yours.
Well, thank you very much indeed for this invitation. It's really exciting to be here and contribute to this inaugural gathering organised by the Cardiomyopathy Council of the Global Heart Hub. So I've been asked to cover a few areas today, and my talk is going to be in 3 parts of perhaps 5 to 10 minutes each, covering some background information about genetics, and then a little look at why genetic testing might be useful, and then a little bit of a discussion around how genetic testing is done. So we'll go back, so start off with the absolute basics, and what is a gene? So a gene is a unit of genetic information that's passed down from parents to their children. It's essentially a segment of DNA that contains instructions for making a specific protein that performs an important function in the body. So here you can see a body. I've zoomed in on a cell. Our body comprises millions, trillions of such cells, each of them highly specialized to a different function. And most of the active components that define what a cell does are proteins. So red blood cells have proteins that carry oxygen. Muscle cells have motor proteins that make them move. Cells in the eye have light-sensitive proteins, and so on and so forth. And our DNA contains the instructions for making these proteins. And different genes are turned on in different cells, and that is what gives us each cell its function. Now, most of the cells in our body have a nucleus that you can see here in orange that contains a complete copy of our genome. And so what you can see in this picture is then chromosome. I've just shown one chromosome, which is a package of DNA. In fact, our cells mostly have 46 of those, 23 pairs, 1 from each parent. And so each of us has 2 copies of most genes, 1 from our mother and 1 from our father. And you can see here that the chromosome, if you were to unwind it, you would eventually get down to this helical structure of DNA that comprises 4 bases that spell out the genetic code. It's about 2 meters of DNA in every cell. And if you were to print it out, this is what it would look like. You can see some tiny font there. And this is at the Wellcome Trust in London. They printed out one of the first genomes. You can see how many volumes that is. And that's how much data is crammed into that tiny space. In fact, I mean, it's much more dense storage than a hard disk drive in your computer, for example. It's really quite remarkable. Cardiomyopathy, then, is a problem with the intrinsic function of the heart muscle. And it can arise from various challenges to the heart, a problem with the blood supply, a problem with the valves of the heart. So, for example, if a valve isn't opening properly, and the heart has to work very hard to eject blood, then like any muscle that has to work hard, it can get bigger and stronger initially, but eventually get weakened. And high blood pressure has a similar effect. Normally, when we're talking about cardiomyopathies, we sort of park those things and we talk about other causes. There are still a number of things that can lead to a cardiomyopathy: exposures to toxic drugs like chemotherapy, alcohol, pregnancy, infections. There are lots of different causes, but sometimes no cause is identifiable. And in those cases, we think that there is often a genetic cause. And in fact, we're increasingly realizing that even when we think we found a specific cause, there may still be an underlying genetic predisposition that we should know about. And of course, a family history is a very useful clue to a genetic predisposition. It's not always present, but when there is a family history, that makes a genetic cause that much more likely. So if you have a cardiomyopathy, it's very important to flag to your doctor if there's a family history of heart disease. Now, there are a few different ways in which genetics can affect health. On the one hand, disruption of a single gene can cause disease. So this picture is showing what's called a monogenic disease, where you have one variant in one gene that takes you all the way from healthy to unhealthy. On the other hand, there are some characteristics that run in families but aren't controlled by a single gene. So, for example, our height. If our parents are tall, we tend to be tall, but it's not that there's a single gene that says you're tall, you're short. There are many factors that contribute to the growth of your bones, nutrient absorption, the timing of puberty. Lots of things affect how tall you end up. And the same is true for the heart. Sometimes many variants in the genome that aren't individually problematic can in combination add up to a less efficient heart. And we've recently seen that some cardiomyopathy comes about like that. And in practice, there can be a spectrum of anything in between. When there is a single faulty gene, we tend to see characteristic patterns in the family. Essentially, that faulty copy is either passed on to a child or it's not. And so we tend to see some individuals in the family who have the disease and others who don't. And with cardiomyopathies, the most typical pattern we see is called autosomal dominant inheritance. It essentially means that there's a 1 in 2 chance of passing on the condition, that both men and women can pass on the condition, and they can pass it on to both male and female children. And this is showing you what the yield of genetic testing for these single gene forms of cardiomyopathy typically is. I've only shown a couple of the most prevalent cardiomyopathies here, but you can see in about 1/3 of cases, when you do a genetic test for a single gene disorder, you find a cause of disease. I would say that about 1/3 of the risk of cardiomyopathy we're now seeing in very new studies is that polygenic form that I showed you a moment ago, where there isn't a single genetic cause, but lots of more common variants, individually all tweaking disease risk a little bit, and they add up in some people to give cardiomyopathy. So that gives you just a brief background to genetics in general and to the genetics of cardiomyopathy specifically.
Fantastic, James. That was really helpful, a really clear overview. So let's look now at genetic testing. What's it for, and how does it really help?
Well, those are great questions. So if we start by thinking about how genetic information is useful, I think we can think, well, why do the doctors do tests for any patient with any disease? Usually we do them for the person in front of us, and we want to either make a diagnosis or get some information about what we call prognosis. That is, we want to make a forecast of the likely outcome, or we want to make some sort of decision about therapy. And so I put here a little snapshot from some recent expert guidelines. These are written for doctors and for experts in inherited conditions in particular, but looking at the different ways genetic testing might be useful for, it says here, a proband, that's someone presenting with disease, across different forms of cardiomyopathy. But unlike other bits of medicine, when we do our tests, we're not just caring for one patient. If we're thinking about a cardiomyopathy, we're also thinking about implications for relatives. And actually, this is, I would say, where genetic testing is most clearly useful, or at least where it first became useful, where it's been useful for the longest. And so I'll start by telling you why genetic testing helps us manage families, and then we'll come back to talking about how it can help us manage patients. So many of the complications of cardiomyopathies can be prevented if we make the diagnosis early. So when we diagnose someone with a cardiomyopathy, we invite their immediate family to have testing to see if they're affected too. And many of you will have experienced this. We have a family member, they have no symptoms, they're invited for a heart scan, and they're waiting to hear, is the scan normal or abnormal? But actually, either way, what happens is they're invited to stay in the cardiology clinic. Well, why? Well, the answer is that many cardiomyopathies, of course, don't appear until adulthood. They might present in your 50s, 60s, 70s. So actually, a normal scan today doesn't mean that you don't have a genetic predisposition that's going to reveal itself later. And so, of course, that can create a lot of worry over a long time. Now, if we rewind and imagine that we had done genetic testing in the first member of the family who was found to have disease, and we can pinpoint the precise genetic cause, so the precise DNA change causing that problem. Well, then instead of doing a heart scan in their relatives, we can do a blood test and see if relatives share that change. And those that do, well, okay, we can start appropriate care. But importantly, those who don't carry the predisposition, we can reassure and we can give them the all clear. And that really is transformative. So I think that, for me, is actually at the heart of why we do genetic testing. Also, understanding the genetic basis of disease allows us to help families to plan. If you have a child with cardiomyopathy, you'll want to know what's the chance that if I have another child, they'll also be affected. If someone has cardiomyopathy themselves, they might want to know what the chance of passing that on is to their children. And if that chance is high, would you like to consider doing something to prevent that? So, for example, having donor egg or sperm, assisted reproduction. There are lots of reproductive choices one might make if you're equipped with that knowledge. So genetic testing is definitely helpful for family members. Returning now to a patient who has cardiomyopathy, let's look at whether the genetic test might actually help them. Well, the diagnosis of cardiomyopathy is mainly by imaging. Typically, we look at the heart muscle appearance, we look at how it performs and pumps on MRI scan or ultrasound. And really, that's usually how we say yes or no, is a cardiomyopathy present. But in some specific instances, genetic testing can reveal something very distinct and importantly distinct. So this is a picture showing measuring an enzyme called alpha-galactosidase in men who have left ventricular hypertrophy, thickening of the heart, that would meet criteria for a diagnosis of hypertrophic cardiomyopathy. So to all intents and purposes, these people have dilated cardiomyopathy if you do an ultrasound only. But we can see down there, about 3% of them have very, very low levels of this enzyme, and that is diagnostic of something called Fabry disease. And crucially, Fabry disease has a very specific treatment. You can replace this enzyme that is lacking. And so there, the diagnosis that you would make just by imaging alone is perhaps not the end of the story. We recognize there's a cardiomyopathy, but if we can go that one step further, we can treat very specifically. Secondly, I talked about prognosis, which is, as I said, a medical word for making a forecast for the future. And this graph is showing patients with dilated cardiomyopathy due to lamin in particular. And what it shows us is that people with cardiomyopathy due to this particular gene are prone to developing rhythm problems and problems with the conduction system of the heart. So sometimes the heart can go too slowly. And knowing this, we monitor for those things very, very closely. And we have a low threshold, for example, for putting in a pacemaker. And we would monitor that in a different way if we knew that particular gene was causing the problem. And then that understanding can lead to differences in how we manage cardiomyopathy. So if we see conduction disease and we're considering a pacemaker for someone with lamin as the cause of their cardiomyopathy, we may take a slightly different tack and we decide to put in it says here, ICD, which is an implantable cardioverter defibrillator. And the reason is because we know if you have significant conduction problems, that can indicate a risk of other rhythm disturbances. And on the right of the picture, you can see from an American expert consensus statement, some of the decision process that a doctor would go through to try and weigh up whether the benefits of an implanted defibrillator outweigh the harms. And you can see what's happened to you before is important, but in the middle there, you can see that genetic testing is part of that decision process. And then when we can weigh up whether the benefits are likely to outweigh the harms, we can help our patients to make decisions about whether a defibrillator is right for them. So that's illustrating some of the ways genetic information is useful to guide some of the therapies we have today, especially when we're trying to target the more costly and burdensome treatments to people who really need them. But increasingly, there are new treatments emerging that aim to address the underlying genetic problem. And so we've seen one already. We've seen that if cardiomyopathy is due to a lack of a protein, we can potentially replace that protein. But increasingly, we're looking at options not to replace the protein, but to replace the gene itself. So there are a number of trials underway. I've put here a press release for a trial in Duchenne muscular dystrophy, which some of you will know is a myopathy affecting the muscles of the limbs and the trunk, as well as the heart. And this is a strategy that could be widely applicable to conditions where the faulty gene leads to a lack of an important protein that you need, and you might be able to put that gene or protein back. Sometimes, however, the problem isn't a lack of a protein. It's the presence of a faulty protein. So hypertrophic cardiomyopathy, due to variants in a gene called MYH7, the myosin heavy chain, arises because the protein is overactive, in fact. And so the question now is, can we switch that protein off? Well, one strategy to do that that's emerging is using RNA therapies. So what you can see here in this picture is in the nucleus of the cell, the DNA is being turned into something called messenger RNA that comes out into the cytoplasm of the cell, where it makes the protein, the myosin heavy chain proteins that form the heart muscle motor. And here we're giving what's called a silencing RNA, another little RNA molecule, which binds very specifically to the faulty copy of the MYH7 gene transcripts. And when RNA forms double-stranded RNA like this, when it binds together, our cells destroy it because it looks like a virus, essentially. So we trigger in the body's own mechanisms to get rid of the RNA. And that way, you can potentially eliminate just the faulty copy of the gene from being expressed. And we can see here, I put some pictures from mice with hypertrophic cardiomyopathy being treated in this way. The heart-marked control is thick, and it has a lot of scarring that shows up in blue. We can see underneath scarring and disarray of the heart muscle cells. And when it's treated, the mice are treated with this RNA therapy, that resolves very nicely. And this is being tried in humans for example, for amyloid, which can cause cardiomyopathy. And finally, and perhaps most recently, we've got tools now where we can directly correct some of the genome changes. So you may have heard about CRISPR gene editing. This article is 5 years old now, and described a proof of principle work to show that you could edit and correct a gene error in a human embryo. And the example that they studied was, in fact, a cardiomyopathy variant. You can see there, causing hypertrophic cardiomyopathy. But there are lots of technical challenges. There are ethical concerns around this sort of genome editing. And actually, pragmatically, if you can put an embryo in a dish in order to do this gene therapy, there's actually something much simpler that you can do, which is simply to test the embryo, find out whether or not they're carrying the variant, and you can put a healthy embryo into the mother potentially and manage the situation that way. But obviously, in an adult, you can't do that. And gene editing to correct genetic faults in adult hearts is an area of really active exploration at the moment. So this I put here, it's a technical scientific paper, but it just came out last month, so I thought I should show it, commenting on 2 studies that did exactly this, gene correction, not in embryos, but in the hearts of adult mice. And there's very exciting work suggesting this toolbox is getting more and more mature, though there are certainly still some obstacles to overcome. But all of those benefits and opportunities require a genetic diagnosis. And unfortunately, as I showed you before, many inherited cardiac conditions, many cardiomyopathies are unexplained. Most striking on this graph, on this pie chart, is I think the grey that shows for most people we don't find an answer when we do genetic testing. Also, very often we do find something, but we don't know what it means. There are millions of DNA differences between the genomes of 2 people. Thousands of those changes are rare. They'll only be found in your family, perhaps a few other families around the world. So a testing lab is not going to have seen them before and can't know for sure what they mean. So we have to try and work out, is this variant that we found, this DNA change that we found, responsible for cardiomyopathy or not? And another piece of uncertainty that complicates the picture, as I said, is that not everyone who has a genetic predisposition manifests the disease. So sometimes we find a relative who carries a genetic variant, we keep an eye on them, ready to act early when they start to develop disease, but they never do. And if we'd known that, we could have spared them all those hospital visits and the healthcare system costs and everything else. So ideally, we need to work out which people with a predisposition are going to manifest and which are not. So I think genetic testing is very helpful in the care of people with cardiomyopathy for their diagnosis, for their prognosis, and to help us treat, select their treatments. And it's also very helpful for family members. But there are some big challenges we need to address to make the most of the opportunities coming up.
Fantastic, James. Thank you very much for sharing that. Obviously getting across the complexity, some of the ethical issues, but also bringing it to life with concrete examples and demonstrating indeed shared decision-making as well. So perhaps now we can look at how a genetic test is done. Can you talk us through how that actually happens in practice? That will be fantastic.
Yes, so we can talk a little about that. I've started here by just showing some headlines of several recent sets of recommendations. There are lots of guidelines aimed at doctors and specialists on when and how genetic testing should be done. The most recent just came out last year. It's from it's a global set of guidelines covering North America, Latin America, Europe, and Asia Pacific. And this is a very rapidly moving field. And there isn't complete consensus. It will change from region to region. But broadly speaking, who should have testing? Well, we should do genetic testing whenever it's going to be useful. And I've talked about when it might be useful. It might be useful for managing a family. It might be useful for managing a patient, for making some of those decisions that I just described to you. I also would say it can be useful for other reasons. Sometimes it's just helpful to know, and there can be big psychological benefits to just having the answer, even when it's not obviously going to affect what you do next. And the way we test normally is we start with the first person in the family who's affected, or the most severely affected person. There are these really 3 reasons that we might do sequencing. The first is in that first person in the family who is affected, and we do what we call diagnostic testing, which is where we sequence the genome to try and find the cause in someone who clearly has the cardiomyopathy. Once we've established the cause in one person in the family, we can then do cascade testing which is to start testing unaffected people in the family to rule out anyone who doesn't carry the predisposition. Now, I think it's important to say we would only start this process once the cause is known in the family. So it's not helpful to test a well person in the family until you know what you're dealing with. And then the third reason we sometimes do sequencing is because we found a variant that we don't understand or don't fully understand, and we're trying to see how it behaves in the family. So at that point, before we're confident, before we would use it to diagnose or make predictions, we just want to see who else in the family has it, because if we can tell that it comes from, for example, if it isn't found in either parent, and it's a new variant that's popped up for the first time in someone who has cardiomyopathy and both of their healthy parents are well, that can be very helpful information to help us to interpret the variant. So normally, so sometimes we do sequencing for that reason. Does family history influence things? Well, certainly, there are some contexts in which you're more likely to get a positive genetic test result. A family history is one of those, but not exclusively so. And so there are certainly contexts in which we might recommend genetic testing, even where we think we've identified a cause in the family, another contributory factor for the cardiomyopathy. So, for example, someone who's pregnant develops cardiomyopathy, we might still recommend genetic testing. At what age would you start testing? Well, the guidelines differ here. The conventional wisdom has been something like age 10 to 12 on the thinking that cardiomyopathies are relatively rare at younger ages before that, and some centres wouldn't start doing regular imaging surveillance until that point. So they would say, well, it's not going to make any difference to the child until they reach that age. But I think increasingly the arguments for testing younger are getting stronger, both because I think we do pick up cardiomyopathy at a younger age, and also because there are other benefits to testing. As I said, the certainty of knowing what you're dealing with, for example. And in my experience, I think children who grow up knowing that they have this predisposition can do very well with that, whereas some children who suddenly get this new information just as they're hitting adolescence at a very turbulent time of life can maybe find it harder to adjust to sort of new information. So I think you have to weigh up a whole set of arguments for and against, but any age can be justified. How's that testing done? Well, it's a simple blood sample or saliva sample. The thing I wanted to flag here really is the importance of genetic counselling that's been alluded to. And importantly, genetic counselling should be offered even actually if you're not doing genetic testing. We're looking for genetic conditions. There are a whole load of relevant bits of information to discuss and go through. So even if not having genetic testing, I think counselling is important. And there are a set of issues that we would want to cover before testing and a set of issues that you would probably want to cover after testing. And they may be addressed by a genetic counsellor or by someone else with training in counselling, depending on the local healthcare system and availability. But genetic counsellors have a great deal of expertise in education, in managing the process, in dealing with providing psychosocial support, in communicating uncertainty and the meaning of test results. So a really highly skilled experts. And the other thing to say is that genetic testing should be done in the context of a specialist team and a specialist with specialist expertise. So normally, you can't just send a blood sample to a laboratory and get a clear yes or no back. There's often needs to be some discussion between the clinician looking after the patient, the laboratory. I talked about some variants we don't fully understand. So there's a lot of dialogue that goes on, and it's important that testing is done in centres where there's the infrastructure to have that dialogue and where you have genetic counsellors, cardiologists, geneticists, laboratory experts, and so on and so forth to really evaluate the whole picture. And then I thought I would finish just by sharing what a genetic test result looks like. So there are really three main outcomes. The first possibility is that we simply don't find any genetic variants that we think might be relevant. And here, the sort of conventional wisdom is, well, this is still could be a single gene disease. It could still run in the family. We should continue to monitor the family. We just haven't got an explanation yet. And that's the position that you'll find in most of the medical consensus documents. But for some cardiomyopathies, I think there's increasing evidence that actually, if we don't find the cause, it's much less likely that there is a cause, or at least that there is a single gene cause. And it's more likely to be this polygenic disease that I talked earlier. And the relevance for that is that that behaves differently in families. It tends to die out over time, if you like, to become less severe over generations, rather than running in the family for across many generations. So that's an area of very active exploration. The second possibility is that we find a causative variant, and that is in some ways good news and in some ways bad news, but crucially it unlocks all these things that I've just talked about. It can really clarify management, counselling, advice, treatment. And the third possibility is that we find a variant that we don't know exactly what it means, and that is a sort of indeterminate result. And that means there's further work to do. And these are the sorts of variants that we will try and study further immediately, and that also we should come back to over time, because as we get new knowledge every year or two, we might be able to revisit that and say, actually, this variant is not relevant, this is a benign change, or actually, I think we've now found the cause in your family. So I just wanted to say one final thing, which is not absolutely directly related to genetic testing, but a brief plug to this community for this resource, the Heart Hive, which came about from discussions with patients who were interested in getting involved in research, including genetic research. And patients were telling us that they find research participation empowering, but that lots of people want to get involved and didn't know how. So this web portal was built with the support, initially with funding from a crowdfunder and support from Cardiomyopathy UK, and it essentially allows people to register themselves as willing to participate in research. No obligation, but you can then see what research opportunities are out there and choose to sign up and participate or not. And this was used, for example, during the global pandemic to run some remote studies about the impact of the coronavirus on cardiomyopathy. When patients couldn't come up to hospital, we were able to collect DNA and genetic tests remotely through the post and gather information using this web portal. So I just wanted to mention that briefly. It's available internationally. I'm afraid it's only available in English at the moment, and most of the studies running on it are studies running in the UK, but it's not limited to the United Kingdom. Genetic testing is undoubtedly helpful. It helps to care for people with cardiomyopathy. It helps to care for their family. Actually, I think genetic testing can be helpful even when it doesn't have an obvious immediate use, if you like. Sometimes it's just really helpful to know, and I think it can be justified at any age at all. So thank you very much for your time and attention. It's great to be here.
Super. Thank you very much, James. I think you've touched on so many really critical questions. Thank you for highlighting the opportunities for patient involvement in research and the concrete examples that you've shared with us. The importance of perhaps testing younger, really important. And this idea of a multidisciplinary approach, dialogue, and the value of genetic counselling, which brings us nicely to our next guest. Before I introduce Ellie, I'd just like to again encourage all of you watching, listening, to pose any questions that you have, particularly anything that you were spurred to reflect on following the presentation from James. We will, as I said earlier, try and address as many questions as possible. But first of all, it's now my pleasure to welcome Ellie Quinn, who is a genetic counsellor at the Royal Brompton Harefield Hospital in London. Ellie, we're also really thrilled that you're with us today. So we've touched on genetic counselling. You actually are a genetic counsellor. What does that job actually entail in simple terms?
Yeah, thank you for having me today. So yeah, my job, I think a lot of it has been really nicely summarized by James, but I'm embedded really in a inherited cardiac conditions center. So we're specializing in conditions like cardiomyopathy. And I work alongside cardiologists and nurse specialists in supporting patients who have cardiomyopathy and their relatives as well. So typically for me, I'll be meeting with patients either who have a diagnosis, so to talk them through what testing involves and help them make the decision about whether they want to have a test. I'm always involved at that early stage as well of sort of gathering the information about the family history, and can be a bit of a detective sometimes in trying to work out, are there other people in the family who've had the condition as well, maybe in the past, trying to bring all that information together so the clinical team can use that going forward. So a lot of my role is that kind of diagnostic role, but then going forward, if we do find a genetic cause for the patient's cardiomyopathy, I'll be facilitating the screening of their relatives as well. So I'll be meeting for those people who are having the cascade genetic testing and helping them make a decision about whether they want to know if they have a high chance of developing cardiomyopathy in the future. And from a wider perspective as well, it's about patients might have questions about starting a family, for example, going through the options that are available for them, thinking about any support needs that might be there, signposting them to relevant patient support organisations. So it's really a holistic model of care, always working alongside the other clinicians to make sure that we're doing everything we can to support patients and their families going forward.
Terrific, Ellie. That's fantastic. We've had a question, quite a specific question. It's almost hypothetical. I'd just love to pose to you now to make it come alive, let's say. Marie, 35, has just been diagnosed with hypertrophic cardiomyopathy. She knows it's possibly genetic, and she doesn't really want to share this with her family because she feels guilty. What would you say to her, and how would you best support her in that context?
I'd say this is a really common reaction. Marie's just been diagnosed with a heart condition. That's enough to get your head round in itself. And then we're giving her this information that you're going to have to be the bearer of bad news and pass this information on to your family, that they may also be at risk. So I'd say guilt is a really normal feeling. Some people think about how are they going to bring that up with their family? How are they going to share that information? So I guess it would be exploring with her what her fears are, how can we support her in sharing that information, but also reassuring her as well that, there is effective screening in place. And actually, it's a good thing that we know this now, because people who in her family may have been at risk can now get checked, and we can pick things up early if we need to.
Yeah. Great. Can I just ask you, is genetic counselling always offered before genetic testing? Is that done systematically these days, at least in the UK?
So I'd say not everyone sees a genetic counsellor. So there's only about 300 genetic counsellors working in the UK, and the amount of genetic testing far outweighs the number of genetic counsellors available. So at the moment, there's a lot of movement to kind of upskill doctors and nurses as well in being able to facilitate those conversations about consent for genetic testing. So I would hope that most people who are offered a genetic test are having at least a discussion and some form of genetic counselling, but they're not always seeing a genetic counsellor.
Right. James, just jumping back to you, are there any downsides to genetic testing? Is there a reason why someone might choose not to test?
I mean, you've alluded to some in the scenario that you just described. I mean, you could argue that knowledge is power. It allows you to make informed decisions, but people react to that news differently. So certainly some people will find it difficult to find, that this condition is hardwired into them. They may feel responsible. They may feel guilty about passing it on to other people. There are also questions around things like insurance. Now, in fact, in the UK, for example, there are strict guidelines on what information insurers can use. By default, you start off with a condition that can run in families, and insurers would know that. And genetic testing can be helpful to prove that some of your relatives don't have the predisposition that might have affected insurance. But there are still concerns about that, and in different parts of the globe, there may or may not be the same protections in place about all different forms of discrimination. So I definitely think there are things to consider, and that's why these counselling conversations are so important. In general, as you can tell from my talk, I'm an advocate that provided people are informed and then decide, yes, this is for me, that it's can be very, very helpful information indeed.
Great. Good. We've had another question, slightly different tack. If money were not an issue, would you want to do genetic testing for all those with a clinical diagnosis of cardiomyopathy? And if not, where would you draw the line? Again, back to you, James. I'll come to you, Ellie, for comments on that as well. First of all, James, please.
Well, I think the answer is if the probability of finding something helpful is lower in some forms of cardiomyopathy than others, for sure. But actually, if money were no issue, then I think, yes, you could offer it to everyone who might plausibly have a genetic explanation where it would be useful. So I think I would say yes. Now, that doesn't mean I would actually want to do genetic testing in everyone, because as we've just said, it's a choice, and there are lots of reasons why someone may or may not want that information. But yes, I would want it to be widely available.
Great. Any comment from you, Ellie?
Yeah, it's a really good question. I feel a bit torn about it, actually, because part of me thinks that we should be, if we could, we would want to offer it to everyone. But then I'm also, on the other hand, thinking, if there is someone with cardiomyopathy and there is another likely cause other than a genetic cause, as James said, the chance of us finding something conclusive is really low, but we may get some inconclusive genetic results. We call them variants of unknown significance. And actually, they can be really unhelpful because it kind of muddies the water. We don't know if we found a definite genetic cause or not. So, yeah, I'm not sure. And I think it's a really good question. Maybe something would be better to be offered in a research setting rather than as a clinical setting.
Yeah. Okay. Good. Another question. My doctor told me that my cardiomyopathy was caused by a virus. Should I get genetic testing? James?
Again, I mean, there isn't an absolutely clear black and white answer here. But we're increasingly seeing that a viral trigger, myocarditis, can uncover a genetic predisposition. People who have myocarditis and then develop sustained problems, I mean, most people with myocarditis recover, but if you do develop sustained problems as a consequence, that could be because genetics is part of the picture. So I think very often testing can be helpful there. Again, you would want to weigh in, if there's family history, then yes, that would be another reason to encourage genetic testing. Again, you come into the practicalities of health services and prioritizing resources and things. But increasingly, my answer would be yes.
Any comments from you, Ellie?
No, I agree. I think obviously we need to weigh it up on an individual level, but I've just anecdotally had many patients who were told years and years back this was caused by a virus, and we do a genetic test and there was actually a genetic susceptibility there. So I think these sort of historic cases, or even more recently, it could be really good to just review things and just kind of question that again, because it can be a combination of gene and a virus as well.
Okay, good. Good. Another question. I have DCM and the LMNA gene, and I'm a parent to 2 young children. At what age should I have my children genetically tested? And again, James, you inferred as early as possible, potentially, certainly before adolescence. And Ellie, I'll come on to you in a second just to ask a little bit about genetic counselling with children in a paediatric setting. But James, what would your answer be to this mother?
Yes, well, as I said, the guideline positions are typically when it will make a difference to the child's care. There's this general principle that we don't want to do something without someone's consent. And if children aren't yet mature enough to make decisions about having potentially life-changing information, we should, if we can, wait until they are. But on the other hand, if it's going to change their care today, if, for example, they would otherwise be coming to the hospital regularly for MRI scans or whatever it might be, and we can relieve them of that burden, then the recommendation would be to test. So the conventional position is, if it's going to change what you do, then test the person. If it's not, then wait until they're old enough to make the decision. But I think increasingly we're thinking, well, it might change what you do. The number of situations where it won't change, you definitely won't change what you do, are very, very few. And we're getting a more nuanced position about thinking about some of the harms of not telling people early, and I think it's just a much more complicated or balanced decision. And really, every family, I think every family should be given the opportunity to decide what suits them and their children.
Very clear, very clear. Ellie, so when it comes to children and young people and genetic counselling, where are you on that one?
It's really tricky because we're balancing so many different things, as James said, the age of the child, when screening for the condition would happen, but also there's a lot of psychological factors as well. The child, are we going to have an open conversation with them? Are they at the age they can have that conversation? Will we need to wait a few years before that we can talk with them about that? Sometimes parents want to do the test and think they could keep that information from their child to protect them. We don't always advise again about doing that. So it really is quite a personal decision in families, and I've had families go one way or the other. For some, the uncertainty can be really unbearable, actually, and knowing is better, even if it's a result maybe they weren't hoping for. Whereas for other families, sitting with a 50-50 is better at that point, rather than knowing either way.
Okay, good. Another question coming through. We're getting quite a few here, so I apologise for sort of buzzing them out to you. I have idiopathic sorry, I'll start again. I have idiopathic cardiomyopathy, but do not qualify for genetic testing by my local health authority. Where can I pay to have it done? Ellie, would you like to? Oh, sorry, please, James.
I mean, there are private companies that do the testing. It probably depends on the country that you're in, and different countries will have different eligibility criteria for genetic testing. So yeah, you have to look at what's available in the country that you're in. But I'd advise anyone who's thinking of genetic testing to do it with a company that also comes with genetic counselling as well, not just one of these direct-to-consumer companies, because you might just be left with something and not really given much follow-up with that.
And maybe I could just add, in terms of finding the right people in any given country, I mean, I think the patient charities and representatives who are part of the global hub here would be a great place to start. So many countries have a national patient voice, and they will be very informed on some of these issues. So in the UK, Cardiomyopathy UK, the British Heart Foundation would be, for example, great places to start.
Great. Another question. I have HCM with MYBPC3 gene mutation. Can the trial medicine you mentioned worked on mice, or does it thin the muscle, or does it just rearrange the cell and reverse fibrosis? Have you ever heard of a connection between a child with HCM from a mother who has gestational diabetes? Two dimensions to a question. First of all, James, please.
Yeah, let's focus on the gene, the various different gene therapies. There are lots and lots of open questions about these, whether they work in reversing cardiomyopathy or whether they only prevent cardiomyopathy. So, whether you have to treat someone from very early on with some of the different strategies that we talked about, either editing a gene or giving an inhibitory molecule, like the RNA therapy I mentioned, whether that you have to start that treatment before the condition manifests, or whether you can start it later and start to either halt progression or start undoing the damage. And the truth is that we don't yet know. These are not things that have been done in humans yet. And I think it's very likely that the earlier you start treatment, the better. But it's also, one has to weigh up the risks of any therapy, and giving a therapy that will have some risks associated with to someone who doesn't yet have any problems raises its own challenges. So I think really we're too early in the process to answer all those questions yet.
Ellie, you're nodding. Anything from your side?
No, James knows a lot more about this than me, to be honest. But yeah, it's a good question.
Good. We've got a question from Australia. My husband has the TTN gene, and the clinic provided us with a simple worded letter to distribute to family members to inform them of the gene, which is a great way to share throughout the family without feeling the need to explain when carrying guilt for being the one to break the news. A few family members have been tested and have also been found to carry the gene. So that was really a reaffirmation of what you were saying earlier. Any comment on that?
Yeah, that's how I typically do things, is to provide like a simply worded letter with what family members, need to do to get checked. So it doesn't give the burden on the patient of having to explain things. I don't usually contact relatives myself. I leave the information with the patient to then contact their relatives. But, sometimes there can be difficult family relationships, and I can always try and help with that in any way I can as well.
Fantastic. So looking now at technology for genetic testing, from your perspective, is this consolidated? Is it reliable? Or is there some work to do in this area in terms of innovation? James, what are your thoughts there?
I think we have a pretty mature technology. I don't think that technical advances are going to move the dial a long way in terms of how much of that cardiomyopathy remains unexplained. I think the tests we have today find most of what is there to be found amongst these sort of single gene forms of cardiomyopathy. I think there are some new technologies on the horizon to measure this polygenic form of cardiomyopathy. And I think at the moment we infer that cardiomyopathy is polygenic simply because we haven't found a single gene cause. But we can measure that, and we could include that in a report. So I definitely think there will be some developments there. And then I think there will also be some incremental advances. We only look at certain parts of the genes. There will be new genes, there will be new regulatory regions that control those genes. So the test will get incrementally better, but not by orders of magnitude. Maybe we'll be seeing a 5% improvement or something, rather than a 50% or 100% improvement.
Great. Ellie, any comments from that perspective?
No, I think I agree with James. We've come a long way in the past decade or so, discovered a lot of new genes, and there are patients where it's clearly a genetic condition in the family and we haven't found the gene that's caused it. So we have a way to go, but I think we just need more research in this area to understand things better, rather than, I don't know if it's the technology, the genetic sequencing itself, it's more the data and bringing all of that together so we can interpret things.
Sure. There's a question now looking at, here we go. Sorry, they're jumping around a little bit, the questions, if you just bear with me a second. I perform a legislative advocacy in the US on behalf of the rare disease community. James referenced the genetic privacy issue with insurers. Have you experienced access payment barriers for either patients or with cascade testing of at-risk family members? Is that maybe more of an American problem? James, please.
Yes, well, in the UK, of course, most of the health provision is through the state and is free at the point of delivery. And I mean, we've had funding issues in the NHS for sure, but I think now we've got a fairly straightforward and equitable system. But in the private system, I have absolutely seen this problem. So, for example, the insurers will say, well, that test is not really to benefit you, it's to benefit your children or your relatives, and they're not our patients. So unless you can tell me why this genetic test is going to influence your management, then we're not going to pay for it. And it's true that the main beneficiaries of the test are the family. But increasingly, of course, it is the case that it will, or at least that it might influence what happens to that patient. So, but over the last few years, we've definitely had that wrangle. But I think it's now one of the advantages, I guess, about the American system, perhaps, is it is a bit more integrated because everyone is private. All the insurers, need to operate in the same way, and so even if it doesn't influence your care, but influences the overall cost of healthcare, it may be covered.
Yeah. Thoughts from your side, Ellie?
No, to be honest, I haven't had a lot of experience that because I work in the National Health Service, so not dealing so much with private testing. I think James alluded before about concerns about getting insurance and things like that. And we're normally quite reassuring about that in the UK because we do have agreements in place to protect people. But yeah, I think it's a whole nother kettle of fish getting the insurance company to pay for a genetic test. Luckily, we don't have so many issues with that in our healthcare system.
Sure. Great. Look, time has zoomed by and we're coming up to the end of our session, our webinar. But before we move to the closing piece, I'd just like to ask both of you, looking ahead, dreams, hopes, aspirations, say in 5 years' time, what would you like to be seeing in the context of genetic testing, James, and for you in the context of actually genetic counselling? First of all, you, James, projecting to the future.
Well, I think we need to recognise the enormous progress that we've made. I mean, we're in a very strong position. We've got a health service that's investing in genome medicine a lot. I think I've alluded to the gaps in our knowledge. Variants of uncertain significance are a cause of a great deal of worry to people, and I think we can get much better at interpreting those. We can either do functional tests in the laboratory to see what these DNA changes do, and gather information from the global community about whether they've been seen in humans and what we know about them. So I think that will improve the quality of testing substantially. I think that understanding when there's more than one variant involved is a big challenge, and I think that will become much clearer. And then I think finally it's telling people how to use that information. We need. I've alluded to all these opportunities where genetic testing might make a difference, and I think that having some of those bear fruit so that we find a genetic cause and then that unlocks a treatment. I think that 5 years is not an unrealistic time frame for us to be trying some of these new therapeutic avenues, and of course that would be really fantastic to see that come to fruition.
Super. Thank you. Over to you, Ellie. Where would you like to see the future of genetic counselling?
Yeah, I think I would agree with James that it would be amazing to be able to come back with a genetic diagnosis and actually say, and there's a treatment for that as well that's tailored to that particular genetic fault that you carry, because at the moment it's just, although it can help with prognosis, a lot of the time it's just a label to explain their diagnosis, and it doesn't change so much for their treatment. I think there's a huge amount of need of people who haven't been offered genetic testing in the past who should now be offered it. People who, slip through the gaps. I've at the moment made it my mission to test all these people who had heart transplants 10 and 15 years ago when genetic testing wasn't available then, and now they're just under a transplant team and it not really being flagged for genetic testing, and actually they're the perfect candidate to find a cause and screen the family. So I think just having more awareness, more people being signposted for genetic testing, hopefully enough resource to be able to offer them genetic counselling, and then if we have new treatments for the future, that would be the icing on the cake.
Super. Thank you. Look, as I say, we're moving to the end of this really, really important session. I think we've touched on so many key points. Very, very warm thanks to both you, James, and you, Ellie, for your excellent contributions, and indeed the Global Heart Hub team for some of the behind the scenes work. And a big thanks to our audience, our participation. The fantastic questions have come through on an ongoing basis, and we could have got on for a few more hours. Please watch out for the International Awareness campaign at the end of June that will involve both Global Heart Hub councils on heart failure and cardiomyopathy, and actually is engaging already very many countries. The campaign will focus on the importance of genetic testing and counselling, and if you'd like to get involved, please do contact the Global Heart Hub. It would really be great to have you on board. Please also complete the evaluation survey that will be in the link. It's also going to be circulated in the next couple of days, so you can actually complete it at your leisure, at your convenience. And we're also circulating the recording of this webinar. So if you've enjoyed it and learned a lot, please do share it with others. That would be fantastic as well. Share it with your network and your community. And I hope very much that you've learned as much as I have during this last hour. So thank you once again, and have a fantastic rest of the day.
Thank you.